Good morning everyone. Today the topic of interest is about preliminary considerations in operative dentistry. So coming to the topic, the preoperative patient and operator considerations are of utmost importance in operative dentistry, as both the dentist and the patient are not supposed to be under any strain during the operative procedures. Coming to the operative positions of the dentist needs to be doing his work under a stress-free environment with a good posture while operating along with an assistant on the patient. Along with it, even the patient position should be in two positions, either a completely supine position or a 45-degree reclined positions. So these are the two positions under which the operator operates on the patient. Coming to the dental chair, principally all the treatments are done on the dental chair for any of the operative dentistry procedures. Coming to the dental chair, pointer right unda ide. Okay. Coming to the dental chair, since all the procedures are done on the dental chair, first let's see the parts of the dental chair. It has got a headrest for the patient which can be adjusted. Along with the headrest, the patient's head also can be tilted either towards right or left or top to bottom in few angulations according to the comfort of the operator. Then comes the seating position. The whole chair can be reclined in supine position, and also the footrest can be used to operate on the patient. Coming to the dental chair, which is used by both the operator and also the assistant, it has got the backrest which needs to be completely support the operator's spine. The operator needs to sit in an upright position with his thighs parallel to the ground and foot resting on the ground. Only then the whole pressure is going to fall on both the feet and balance the stress. The assistant's stool always needs to be 4 to 6 inches higher than the operator's stool. The assistant stool with footrest and abdominal support is on the left side, and also the doctor's stool with the back support is on the right side. The assistant is on the opposite side of the operator, and he keeps assisting the doctor in a zone called the exchange zone. Through the exchange zone, which is below the chin of the patient and above the chest of the patient, there is a zone called exchange zone where the assistant keeps exchanging the instruments with the operator. That is the reason the operator's stool needs to be at least 4 to 6 inches higher than the operator's stool. Coming to the patient sitting position, the patient is sitting in an upright position here, as you can see in the dental chair. As soon as the patient comes, we need to examine the patient and write down the findings. So this is the patient's position which is very comfortable for the operator to check. Other than this, when you are operating on the patient in standing dentistry, you can go for a reclined position of 45 degrees, and otherwise you can go for a complete supine position. This is the patient in supine position in the dental chair. This is the most commonly used and comfortable position for the patient and also the operator. Coming to the neutral seated position, this picture shows here how the operator needs to operate on the dental stool. The forearms are parallel to the floor and the weight is evenly balanced everywhere. The thighs are parallel to the floor, and you have to make sure that the head of the patient is at the level of the elbow of the operator. The hip angle needs to be at 90 degrees angulation, and the seat height is positioned low enough so that you are able to rest the heels of your foot on the floor completely, not on the wheels or in the air, but they have to completely rest on the floor. Coming to the chair positions, there are several chair positions different for right-handed dentistry and left-handed dentistry. Here, as you can see in the right-handed dentistry, there are 4 primarily used positions, like the 12 o'clock position, 11 o'clock position, 9 o'clock position and 7 o'clock position. The 12 o'clock position is called as the direct rear position. This position is used commonly for both right-handed dentistry and left-handed dentistry. The other three positions exclusively used for your right-handed dentistry are 11 o'clock position, also called as the right rear position. That means you are behind the patient, slightly positioned towards the right of the patient, and this is a universal position where you can access almost all the teeth from these positions. So the 11 o'clock position is called as a universal position and most commonly used position. Then comes the 9 o'clock position, which is exactly right beside the patient. The teeth which you can access through the 9 o'clock position are the facial surfaces of the maxillary posteriors and the occlusal surface of the mandibular posteriors. In 12 o'clock position, it is mainly used to access the lingual surface of the mandibular incisors. When you come to the 7 o'clock position, which is called the right front position, from here you can access the facial surface of the maxillary anteriors and mandibular anteriors. And also coming to the left side dentistry, where all these positions are changed for a left-handed dentist. The same positions are changed into 1 o'clock, 3 o'clock and 5 o'clock positions. So you have to just apply the same thing towards the left side of the patient. The similar things are shown in the picture. So this is a diagrammatic representation of how you can visualize the 12 o'clock, 11 o'clock, 9, 8 according to your position of the operator. In the 11 o'clock position, you can access almost all the teeth from that position. This is the picture representing the left-handed dentistry, where it is accessed through 1 o'clock, 3 o'clock and 5 o'clock positions. So to achieve a good result in your operative dentistry, after having a good operator and chairside positions along with the patient comfort, you need to address isolation. The goal of isolation is for a complete moisture control. So by moisture control, you are going to have a good access, dry environment and good quality of your treatment. The next one is your retraction and access. Along with the moisture control, whatever measures you are taking for the isolation, what you can do is retract and access the soft tissues, hard tissues, and also help in elimination. The next one is harm prevention. Due to the rotary instruments used and also the small endodontic instruments used in operative dentistry, you can always prevent the harm to the tongue, cheeks, lips, any soft tissues by having a good moisture control and retraction. So the primary objective of your moisture control is complete retraction, complete moisture control, which can be obtained through the use of rubber dam. So the rubber dam is the utmost primary important in your operative dentistry because it gives you almost 100% of your moisture control, and this is most commonly used and recommended means of moisture control. Along with the rubber dam, there are several other things which can be used, like cotton roll isolations and cellulose wafers. Not only in the operative dentistry but in general in the dentistry, when you use crowns or any prosthesis for cementation or for temporary cementation or checkups, you can always go for cellulose wafers to avoid any ingestion or inhalation of these small prostheses. Throat shields, high volume evacuators and saliva ejectors for moisture control. Retraction cords for, as we all know that the moisture should be controlled not only from the saliva but also the gingival clavicular fluid and the blood. So the gingival clavicular fluid moisture control can be obtained through using the retraction cords, and also the mouth props for proper opening, and mirror and evacuator tip retractions, and also finally rarely used in dentistry but also drugs can be used for the moisture control. So these are the pictures showing how we use the cotton rolls. Most commonly used by the students are the cotton rolls placed in position. The position of the cotton roll is based on the opening of the salivary gland duct. So based on the opening of the salivary gland duct on the lingual side of your mandibular jaw and the buccal side of your maxillary jaw, we recommend the insertion of these cotton rolls for maximum absorption of saliva and also blood, anything if comes under the treatment. These are the throat shields which completely cover the throat and prohibit any harm in like ingestion of any processes. Suction devices, these are some of the suction devices shown in the pictures, the high volume evacuators and saliva evacuators. These are disposable tips which come under different colors and plastic. These are attached to the suction devices present already given in the dental chair, and as soon as the treatment is complete, these are disposed immediately. These are the high volume saliva evacuators. These are used when you are performing minor surgery or impaction. When you need high volume evacuation, then you use these high volume evacuators. Are preferred for suctioning because these remove the water slowly, and place tip of the evacuator just distal to the tooth. Any case when you are doing cavity preparation or any other treatment, the place where the salivary evacuators are placed is right distal to the tooth involved. The tip should be parallel to the facial or the lingual surface of the tooth acing the prepared. The low volume saliva ejectors, these are most commonly used on daily basis. These are meant to remove the saliva that collects at the floor of the mouth. When used with the rubber dam, pass through a hole in the rubber dam or beneath it. So when you are using the rubber dam for isolation, we usually confused where to place these saliva ejectors. You can either place a hole through which the saliva ejector goes under the dam, or also you can lift the dam and place the saliva ejector for the comfort of the patient. They must be smooth and made of non-irritating material which does not react or irritate the human skin. These are the gingival retraction cords. These gingival retraction cords are made up of cotton or synthetic woven. There are many types of cords like braided, non-braided, plain or impregnated. Braided and non-braided is nothing but based on the thickness of the gingival retraction cord, and also plain and impregnated is they might be impregnated with a chemical like adrenaline for a more better moisture control through adrenaline. These gingival retraction cords are placed in the gingival sulcus, and after the treatment and necessary impression taking etc., these retraction cords are again removed from the place. These are called the mouth props. There are different sizes of mouth props like small, medium and large. These are used when you are doing a lengthy appointment case and the patient needs to open the mouth for a long period of time. So these help the patient to open the mouth as they bite on these mouth props. These mouth props are of different designs and different materials are available like block type or ratchet type, as you can see in the pictures. The benefits to the patient as it relieves them from maintaining adequate mouth opening. So few times when you have a lengthy appointment, the patient keeps closing the mouth due to tiredness of his jaws and muscle strain. So these mouth props help even the operator and also the clinician to open the mouth for a long period of time. For the dentist, the prop ensures constant and adequate mouth opening for an uninterrupted procedure. These are called as cheek retractors, tongue retractors, and the mouth mirror is also used for retracting the cheek, lip and tongue. So as you can see, there are some tongue depression retractors in the second picture, the cheek retractors in the first picture, the mouth mirrors. So all these things, as you can see, they are doing using a disc for reducing the tooth structure proximally, and the lip retractors used there are protecting the lip from injury. The last one is called anti-silogogues. The anti-silogogues are rarely used in dentistry, but in few cases when there is not adequate moisture control, in spite of using all these preliminary considerations, we go for a medical giving them the anti-silogogues. The anti-silogogues example is atropine. This atropine is used half an hour before the appointment, and by giving this there can be an adequate moisture control as a last resort. And also the anti-anxiety drugs. The few patient to decrease the anxiety and for the patient to cooperate for the treatment, you need to give them an anti-anxiety drugs like diazepam and barbiturates. Diazepam 5 to 10 milligrams or barbiturates 24 hours before the appointment, and also muscle relaxant also can be tried on the patients with anxiety. Thank you.